Okay, good afternoon, everyone. Happy to have you here for the Health in the Public Interest weekly seminar. Today we're featuring Dr. Matthew Biel from Georgetown University um, and its hospital. And I think it's a very timely seminar given, that children's trauma and its effects are kind of on everybody's mind these days, I think. He's not directly talking, I don't think, about those issues, but things that are certainly applicable. Our program, the Health in the Public Interest program, emphasizes the non-medical factors that affect health, particularly social determinants, political, economic, etc. You can look at our website, which Elizabeth has put in the chat. And I just want to say that the way we're going to run this, Johanna's going to give a brief introduction of Dr. Biel, and then he's going to speak until right around 12:45, and then we'll have about 15 minutes, we hope, for question and answer. We have a hard stop this week at 1 instead of 1:15, so I'm not going to waste any more time. Johanna, please take it away.
Okay. Good afternoon, everyone. I'm very excited to introduce this week's guest speaker, Dr. Matthew Biel. Dr. Biel serves as the chief of the Division of Child and Adolescent Psychiatry at Georgetown University Hospital and is a professor of clinical psychiatry and pediatrics at Georgetown University School of Medicine. He also co-directs the Early Childhood Innovation Network, which is a citywide effort to improve developmental outcomes for children and families here in Washington, D.C. Dr. Biel's research at Georgetown focuses on addressing health disparities affecting identification and treatment of mental illness and developmental disorders in children and adolescents, with a specific focus on the early identification and treatment of autism spectrum disorders in minority youth, and is also working to develop mental health interventions across a range of conditions that can be effectively delivered in both primary care and school settings. Additionally, he's working on projects to support children and families facing developmental disorders and coexisting medical and psychiatric conditions. Dr. Biel's clinical efforts focus on children and adolescents with anxiety and stress disorders, trauma-related conditions, autism spectrum disorders, and complex medical illnesses. He has published numerous articles and is involved nationally in psychiatric education and advocacy for children's mental health as co-chair of the Committee on Health Promotion and Prevention at the American Academy of Child and Adolescent Psychiatry. Dr. Biel received both his medical degree and a master's degree in community medicine at Mount Sinai School of Medicine, and he completed both his residency in psychiatry and his fellowship in child and adolescent psychiatry at NYU Medical Center. As a quick fun fact, Dr. Biel is a very proud father of 2 teenagers who are the source of a lot of fun in his life. And he was initially drawn to this field from both a love of neuroscience and the idea of working in a field of medicine that prioritizes understanding people's stories. So with that, I would like to welcome Dr. Biel to our seminar series. We're very excited to hear from you and thankful you've made the time to be with us today.
Thank you, Joanna. That was very kind and embarrassingly long. I apologize to everyone for that already. It's great to be with you all. I'm sorry we're getting a bit of a late start, and it's particularly nice to see a couple of old friends among the faces on the screen. So really glad to be with you all. Thanks for the invitation. And I'm gonna jump right into it, and I'll encourage everyone to feel free, it's hard for me to follow the chat, but if you want to just interrupt by voice, I'm happy to pause and address questions or concerns or protests along the way, and I'll be sure to stop in time to have a few questions at the end as well. So again, the focus is on childhood adversity, and in particular how traumatic stress can affect health across generations. So the more experience I have in the field, the more I'm convinced that the seat of health, both good health and troubling health, lies in families and how families live together and how families function across generations. And so that's really impacted my thinking quite a bit. So the overview of what we'll talk about is a little bit of a background about trauma and some terms that you probably heard just from reading the paper and from popular media about these things called toxic stress and adverse childhood experiences, or ACEs. Talk about how childhood adversity can impact health, behavior, and learning, which really all are part of the same thing, which is how kids' brains function, affect their health, behavior, and learning, both during childhood and across the lifespan. Talk about intergenerational effects, and then about how we promote resilience through safety and primarily really through relationships. The relationships are really the key to health. So early adversity, until 25 years ago, it was thought that what happened to kids in the first few years of their life didn't really matter that much. They didn't really have much language. They were just, as long as you fed kids and kept them warm and kept them dry when they were babies and toddlers and preschool, not much else mattered. And we've learned that, in fact, it's quite the opposite, that there's so much profound development of the brain, and as a result of personality, of interpersonal skills and social skills, of the capacity for learning and growth and adaptation that happens in the first several years of life, that in fact early adversity has a profound effect on life on health throughout the lifespan, including on biological functioning, psychological functioning, learning, achievement, all of the outcomes that we care about. This is not a neuroscience class, but it's just there's some grounding ideas that are really important, which is, really brain development starts at conception. It starts at the very, very beginning, and brain development is most robust, most dynamic early in life, really in the first 3 years of life. Early experiences that we have, so those are positive experiences of being nurtured and cared for, or experiences of being neglected or abused or otherwise not having basic needs met. Those are embedded. Those become part of our biology. They change our DNA. They change the way that our organs develop. They change the way that our brains develop. They change the way that our hormones are expressed. All of those biological functions are directly affected by early experiences. And as I said before, brain functioning is sort of where all of these factors meet in terms of predicting physical health, mental health, and learning. So, I think when people used to think about trauma, when I was training in the late 90s and learning about trauma from some of the world experts in trauma and PTSD, trauma was thought about it as an experience that was rare, that happened in extreme circumstances, like in war, like in natural disasters or man-made disasters. We have no shortage of those to think about. And that trauma was something that happened to the unlucky few who were exposed to these kinds of extreme human experiences. And I think the field has really moved to considering newer concepts of trauma that oftentimes put children in the line of sight. Those include very recent things like separating families at the border, like experiences of homelessness, and refugee status and dislocation that affect millions of children and families around the world. And so trauma, unfortunately, we're understanding is much less uncommon, much less rare than we used to think about, and is actually a really common part of many, many children's lives. And I'll share some data about that shortly. Stress and trauma are not the same. So trauma is an experience that is overwhelming. Stress exists along a continuum. There's good stress, and most stress that children experience is good stress. It's brief, it's developmentally manageable. It promotes children's development of learning and independence. So moving from one town to another town, having a conflict socially at school, having an academic challenge that is difficult to meet, really struggling in math and needing to get extra help in math. That's certainly very stressful for kids. That's actually a positive experience in kids' lives. It promotes, again, the development of the capacity to deal with hard things. Tolerable stress is sort of the next sort of place on the continuum. Tolerable stress is stress that you don't wish upon any child. Tolerable stress might be losing a grandparent, or experiencing bullying, or some other kind of thing that happens that unfortunately happens commonly in childhood, but is tolerable if the adults around that child, if their parents, caregivers, grandparents, aunts and uncles, teachers, coaches, a clergy member that's in the child's life, are able to buffer that experience by helping the child to understand it, helping them to develop coping strategies, helping to get through that and move through it and come out on the other side saying, I survived something that was difficult and I'm stronger for it. Toxic stress is the furthest end of the continuum, and that's stress that is most importantly unbuffered by adults. It's daily, it's unrelenting, it's traumatic, and the adults in the child's life are not able to support or buffer the child through that experience. So there are kids who live a couple of miles from where I'm giving this talk who hear gunshots in their neighborhood every week. Now that's an overwhelming experience for a child. There are many parents and caregivers in those kids' lives who are able to buffer that stress to help kids to feel safe and protected, even in a situation that feels out of control. And those kids are not necessarily experiencing toxic stress or trauma. They're certainly experiencing something that we wish weren't happening in their lives. But it's the kids who are experiencing daily or weekly gunshots in the background who don't have any adult in their lives to explain what's happening, to help them to feel safe, to help them to calm down, and to feel that they've got some protection around them. Those are the kids that we really have to worry about. So common sources of trauma and toxic stress in kids' lives. So these categories include abuse, so emotional or physical or sexual abuse, neglect, so emotional and physical neglect. And in fact, a lot of longitudinal research shows that experiences of neglect in childhood are actually the most likely to be harmful and damaging in the long run for kids' lives. And then things happening in the home and community environment, so prolonged separation from caregivers because of immigration or because of incarceration, exposure to violence in the home or in the community, having a primary caregiver who has untreated mental illness or addiction, or growing up amidst extreme poverty, housing instability, homelessness, or real food insecurity. These are the most common sources of toxic stress and trauma in kids' lives these days. And I'm guessing, I hope that some of this is repetitive. I'll try not to be too repetitive, but some of you may be hearing it for the first time. The ACEs study was a study that has now been going on for 30 plus years. The first papers started coming out about it in just around 2001, 2002. The research started in the late 90s, and it was a CDC study that attempted to quantify early adversity. So there was a population of middle class, largely health insured, mostly white Southern Californian adults that were studied starting in the mid 90s. And they were asked about, as adults, did any of these things happen to you when you were a child? And there were a list of 10 experiences. And each time that if someone said, yes, this thing happened to me, they got a score of 1. If one of the 10, you had a score of 1. If 4 happened, you had a score of 4. If 8 happened, you scored 8. And what was found in the study, in data that continues to come out, is that a higher ACEs score predicts long-term outcomes for those people. That even though the adversities happened in childhood, the outcomes are happening in adulthood. And that included physical health outcomes like obesity, diabetes, cancer, heart disease, premature death, reproductive health, including early pregnancy, sexually transmitted illnesses, risky sexual behaviors, mental health outcomes like depression, psychosis, addiction, memory loss, early dementia, suicide, and also really interesting non-health outcomes like likelihood of unemployment, likelihood of being involved in the criminal justice system. And in a fascinating way, there was a dose-response relationship for these outcomes, meaning that for 1 ACE, your risk was slightly higher. For 2 ACEs, it was higher. For 3 ACEs, it was higher still, and it went up in a linear fashion. And I'll show you those on some graphs in a moment. So compare with people who had 0 ACEs, people with ACEs of 4 or more were 2 times as likely to smoke, 12 times as likely to attempt suicide, 7 times as likely to be alcoholic, 10 times as likely to inject drugs. Compare with people who had 0 ACEs, people who had an ACEs score of 6 or higher had a shorter lifespan on an average of 20 years. Now, if you compare that to smoking, being a daily smoker reduces your lifespan by about 8 or 9 years. So this is a much greater impact on long-term health, long-term lifespan, than even health behaviors that we know are extraordinarily harmful to your health. I hope that you can see this slide, but this just lays out some of the ways that ACEs affect health, likelihood of injury, mental health outcomes, maternal health outcomes, infectious diseases, chronic medical diseases, risky health behaviors, and opportunities across the lifespan. So I'm going to show you just a few graphs that depict the dose-response relationship. This is the likelihood of developing alcoholism as an adult, according to your ACE score of 0 through 4 or more. You see the linear stepwise increase. Likelihood of becoming a smoker as an adult, according to ACE score from 0 to 6 or more ACEs. Likelihood of having chronic depression as an adult in both women and men, according to 0 to 4 or more ACEs. Women with 4 or more ACEs, you'll see have a lifetime likelihood of chronic depression of over 50%. Likelihood of attempting suicide at some point in your life, depending on your ACE score of 0 to 4 or more. These graphs, you'll notice these graphs all look the same. The dose-response relationship is the same throughout. Likelihood of perpetrating domestic violence. So abusing your spouse or partner, abusing your children for women and men, from a 0 to 5 or more ACEs. Likelihood of being sexually assaulted at some point in your life, according to your ACE score, to 0 to 4 or more. Sexual behavior during adolescence, likelihood that you're going to have intercourse by the age of 15, become pregnant as a teenager, or become a father as a teenager, according to your ACE score. So you see that all of these things have the same stepwise dose-response relationship that's quite profound. This is from another study looking at people who are offenders, so who are convicted of crimes, and the likelihood of their ACEs score being 4 or more, compared to a sample of adults who are never involved in the criminal justice system. So I think from the standpoint of your course of study, I think a way to think about this is from the standpoint of public spending and public priorities. And so I think a way to reframe this is that a significant percentage of the billions and billions of dollars that we spend on healthcare, so treatment of chronic healthcare conditions, diabetes, cancer, dementia, the money that we spend on addiction, mental health care, on criminal justice, on incarcerating thousands and thousands of people every year, on emergency services, social services, all of these billions are spent as a result of what happened to children at home and in their communities when they're young. These are preventable outcomes. And the second point is that ACEs are ubiquitous. They're not limited to certain neighborhoods or certain zip codes. There are people with 5, 6, 7 ACEs living in every home, on every block around this country. This is not just a problem related to poverty. However, the experience of growing up in extreme poverty is sort of an uber ACE. It elevates the risk of exposure to all other kinds of adversity. And so the fact that we're the wealthiest country in history and we tolerate rates of childhood poverty in our country of over 50%, to me is pretty egregious. This is just another depiction from the CDC about how this process flows from conception to death. So experiences early in life of adversity then change social conditions, disrupt neurodevelopment and brain development, lead to social, emotional, and cognitive changes, lead to adoption of health risk behaviors like smoking or unhealthy food choices because of food insecurity or because of difficulty coping with stress, which then lead to disease, disability, and social problems, and then lead to early death. This is the progression, if it's uninterrupted, of adversity that affects children. Just a few important points about neurobiology and trauma. So toxic stress, so living as a young child and experiencing toxic stress, living in a home where abuse or neglect is happening, living in a home with extreme poverty, not regular access to healthy food, it changes brain growth. So there are observable differences in the size of critical brain structures that we can see before the 5th birthday in children who are growing up in very high adversity settings. So the idea that children show up for kindergarten at age 5 and everyone's on the same playing field, all kids are ready, get here at age 5 and off you go. It's not true. Kids are showing up at age 5 with 5 years plus 9 months of experiences, either positive supportive experiences or adverse experiences that are affecting the way that their brains are shaped and functioning by the time they get to kindergarten. You can see that in specific brain functioning tests as well. Executive functioning skills, emotional regulation skills, social skills are all different by age 5 in kids who've experienced high rates of toxic stress. So you can imagine all the ways that this affects mental health. So the skills that we acquire that are brain-based skills that we acquire in our first years of life are critical for emotional functioning. You're only 3 years old once. You only learn the skills that a 3-year-old needs to learn for how to resolve conflict with peers and how to share and how to take turns and how to sort of not act on an impulse, but sort of wait for a better moment for it. Those are skills that you learn when you're 3. If you don't learn them when you're 3, you're falling behind. And if you're living in an environment that's highly adverse, the development of those higher order cognitive skills are taken offline in favor of just trying to survive. We know that adversity in early childhood is a huge risk factor for later onset of major mental illness. If you go into Georgetown University Hospital and go to the psychiatric unit on the 5th floor and see people who are hospitalized for psychiatric crisis, who have diagnoses of schizophrenia or bipolar disorder or borderline personality disorder or PTSD, or cocaine addiction, that problems that land them in the hospital, and you check their ACEs, almost without fail, they've got ACEs scores of 5, 6, 7, 8, 9, 10. These are individuals with very high rates of adversity during early childhood that tipped over their risk for mental illness into the category of developing those illnesses. So, if you have kids who are growing up in scarcity, they behave accordingly. They behave in a way that they're trying to survive, and they're not able to develop these higher order skills on time. Now, I'm speaking about this in a way as though it's faded or unchangeable, and it's really important to emphasize that that's not true. This is when the stress or the adversity is unbuffered. When children, even in adverse environments, have supportive, attuned relationships with adults, that buffer from relationships positively impacts health and creates opportunity for resilience and positive growth. And so that this is not a one-way ticket to poor outcomes. Physical health, you see many of the same factors. People who have high levels of toxic stress have elevated stress hormones, elevated cortisol and adrenaline. Their immune systems don't work as well. Their inflammation responses are exaggerated. Metabolism is disrupted. So the regulation of energy and food intake is disrupted. And so you see high rates of obesity in people who've experienced lots of adversity early in life because their metabolic pathways are disrupted. Affects the maturing organs, the heart, the kidneys, the lungs. But again, this is unbuffered stress. When the stress is buffered by competent adults who are able to provide kids the environments that they need, you don't see the same progression towards these poorer outcomes. I think it's critical as we start to think about how to be hopeful here and where do we build from, is to think about both adversity and resilience as being intergenerational. Parents who've experienced trauma in their own lives are more likely to suffer the physical, mental, and social impacts of those traumatic experiences, and that sometimes reduces their ability to buffer the impact of adversity on their children. So a parent who's experienced a lot of trauma, who now has depression as an adult, or is using drugs as an adult to cope with their depression, is going to be less available to their child to provide a buffer to protect their child from potential experiences of adversity that are happening in the present time. However, if we support parents in recovering from their own experiences of trauma or emotional distress, those parents then can thrive as adults and be the parents that they want to be to their children, and are then enhancing their ability to raise resilient children for the next generation. So there are numerous opportunities for intervention here. When caregivers are distressed or overwhelmed or abusive or unavailable, their children's ability to build interpersonal relationships that are positive and nurturing are then impaired. All of these skills build early in life: empathy, emotion recognition, reading social skills, or reading social cues rather, and building social skills. Those skills develop early in life. The way that you develop empathy is by someone empathizing with you. If you're a toddler who is hungry and is crying, and an adult comes in and says, "Oh, what's wrong, honey? Are you hungry? Are you tired? Let's figure out what's going on." That experience of empathy, if someone trying to get in your shoes and understand your distress, that's how you then build empathy for the next person. And toddlers by 16, 18 months of life who are developing in a nurturing environment are expressing lots of empathy for other children who are in distress. However, if you're a toddler who's 16 months old and you're crying and hungry or tired and no one is coming to help to figure out what's going on, you don't experience empathy, you then are, of course, delayed in developing your own capacity for empathy towards other people. The relationship between children and their primary caregiver or caregivers is the template, it's the paradigm for every relationship that comes thereafter. So this is why I've come to spend a lot of the time that I spend in doing research and program development in early childhood, because there's such an opportunity for intervention. It's the time where brains are most plastic meaning most receptive or responsive to intervention, most responsive to change. There's multiple points of entry. You can do work with young children or with the adults in their lives and influence things positively in both directions. You can do interventions in the healthcare setting, in preschools and educational settings, in community settings, in faith-based settings. There's so many different places where children and families spend their time where there are opportunities for intervention. So what does intervention look like? I think at a first level, it would be great to do primary prevention, to do public policy interventions that actually reduce the incidence of ACEs, that reduce the likelihood that children are going to experience adversity early in their life. So creating opportunities for stable, affordable housing, for access to secure and nutritional food, for creating safer, more secure, more organized, less chaotic neighborhoods, for treating mental illness and addiction early in parents, ideally before they become parents, but certainly once they're parents as well. Improving individuals' access to social capital so that they can make changes in their own lives and set goals and start to reach those goals. Limiting family separation for any reason. Family separation is just an unnecessary adversity for young children. And addressing all the systemic examples of racism and discrimination that impact people's ability to build the lives that they want to build, including the economic lives that they want to build. So this is at the level in public health speak of primary prevention. These are all primary mental health prevention interventions. If we know any progress we can make in any of these areas. Second level of intervention, this would be sort of secondary prevention in public health speak, would be introducing effective interventions that potentially can buffer the effect of toxic stress. So accepting like there is adversity that's affecting children and families, how can we buffer the impact of toxic stress by promoting healthy relationships and safety for that child and that family? This is a lot of the work that we do is trying to build these second levels of interventions. So when people experience a stressful life event, it's important that there are individual differences in how people respond. People don't respond in the same way. Some people are sensitized and end up becoming much more vulnerable to experiencing distress or even mental health problems or mental illnesses later in their lives. And some people are resilient. Some people build the capacity to experience something that's difficult and stressful and to respond with greater strength, with recovery, and with a greater capacity to thrive and to adapt. So those things are not preset. I think some people talk, there's a lot of discussion about resilience these days in healthcare, and I think sometimes people have the misperception that resilience is something that you're either born with or you're not. You sort of got it or you don't. And I think that couldn't be less true. Resilience is something that people develop with appropriate support and with opportunities for growth. There's some things to keep in mind when thinking about who becomes vulnerable and who becomes resilient. I think acute life stressor, so a life stressor that happens one time, and then things sort of return to normal. So something that someone experiences, like a family experiences a car accident, or a family experiences an unexpected death of a family member. Extraordinarily traumatic and stressful, but it ends, and then there's an opportunity for recovery. There's much more likelihood of resilience in those situations than situations in which there is chronic adversity, in which the adversity goes on and on and on, and there's no relenting. There's no relief from it. I can't emphasize enough how important parental factors are. When a family experiences a trauma, the biggest predictive factor for how the child is going to do emotionally and behaviorally is how the parent does. When parents are able to cope, kids usually cope. And when parents are not coping effectively, kids are not going to cope effectively. And so oftentimes the first order of business is to figure out how to help parents to cope better. Social factors are huge. So the way that media covers events that happen that affect, a natural disaster or a war or an act of terrorism, the way that media covers that and communicates that to the population has a big effect on whether that becomes an ongoing trauma or becomes something that sort of is contained and people are able to move past. There's a concept of sort of organized versus disorganized communities. So communities that have a lot of social support and institutions within the community that support one another, recreation centers and churches or other religious organizations that create sort of formal and informal kinds of social support. Those kind of organized communities respond better to stress and trauma than communities that are more disorganized, where it's sort of every person for themselves and there's less of a social fabric supporting people. Biological factors are obviously huge. Genetic factors do predict how people cope. How likely someone is to develop a post-traumatic stress disorder or depression after a trauma versus how likely they are to recover. Biological factors, including the functioning of our hormones and our stress systems, that's what the HPA axis refers to. Those are different among different individuals as well. And psychological factors are different too. We all have different ways of coping. Now, of course, we can learn new ways of coping that are not just our native ways that we were born with or that we're naturally drawn to. Some of us have ways of coping that are naturally more productive in the setting of a traumatic or or anxiety-provoking situation. Some people tend to be more avoidant or more sort of coping in a way that's less adaptive. But those people can learn with appropriate support how to cope in more productive, adaptive ways. And this is just a little bit about the numbers of, sort of how often do children experience trauma or adversity. In a national survey of teenagers, 8% had experienced sexual abuse by age 17, 17% had experienced physical assault, 39% had witnessed violence in the home or in their community. Another study in North Carolina, a really high quality study, total of 68% had exposure to some kind of trauma by their 16th birthday. And 20% of those whose exposure to one trauma had developed some kind of psychiatric or mental health problem. 50% of those who had multiple traumas had developed mental health problems. So that sort of illustrates the degree to which these things can be additive. Experiencing one trauma is a risk factor. Experiencing multiple traumas is a much greater risk factor for developing mental health problems as a result. And of course, these numbers are improved when there's appropriate timely intervention that's provided to people. So I wanted to, I'm trying to be mindful of time, and I think we can do this. Just sometime and have time for questions. So I wanted to share sort of a clinical example of like how this comes up for those of us who are seeing patients in various healthcare settings. So imagine those of you that are in healthcare, you can imagine this easily. Those of you who don't work in healthcare can put yourself in our shoes easily and thinking about what shows up in the clinic. So imagine that you're working in a pediatric setting. And it's a clinic that serves a diverse range of patients and families from a range of cultural backgrounds and incomes, with private and public insurance. And there's an appointment for a 4-month-old male infant who presents for a scheduled well child visit. That well child visits are pediatric visits where you're coming in. It's your 4 months, it's time for a visit. We're going to do a checkup. We're going to do some vaccines. We're going to sort of see how everything's going. And you're a mental health professional, and your pediatrician colleague sees this family and says, I'd love for you to talk to this family and see what you think. So clearly the pediatrician is concerned about something. And your practice also has a social worker that works there, and that you'd be able to sort of involve them in this patient's care as well. So you might be thinking about, if you're going to see a mom and a 4-month-old, okay, what might be going on with the mom? Is 4 months after birth, that could be an important age to think about postpartum depression or anxiety in the mom. Has she returned to work yet? How's that going? Is she breastfeeding? Is that going well, or is that a source of stress? Does she have a co-parent? Is there somebody else who's helping her to parent this infant, or is she on her own? You'd be looking for factors in the child. How is the child developing? How are his motor skills, his early language skills? A 4-month-old should be starting to babble. How are their senses developing? Hearing and vision, and motor coordination. Are they developing socially? Like 4-month-olds should be making eye contact and using a social smile and starting to engage socially. Is this baby sleeping well? Is he feeding well? And then what's happening in the relationship between the child and the mom? Is this baby soothable? Is he bonding with his mom? Or is this baby that just kind of cries all the time and there's nothing the mom can do to calm him down? And then what are the social factors going on in this family's life? Where do they live? Is it safe and stable housing? Do they have access to good food? Is the mom eating well enough to support breastfeeding if she's breastfeeding? Is she working? Do they have financial support? Is there violence where they live? Does the mom have anyone who's helping her to raise this child or providing a social network for her? So before I walk into the room even and meet this family, these would be the things that be sort of stirring in my mind. So let's imagine these are our first observations, that you enter the exam room and the mom is sitting in a chair and she's looking at her phone. And the baby's in a car seat carrier, one of the ones that you can carry the baby around from the car, that's set on the floor and it's facing away from the mom. You sort of look around into the carrier and the baby's awake and alert and tracks you with his eyes when you enter. The mom looks up and responds to your greeting. She says quietly, "Good morning." You notice that she seems tired and she agrees. She says, "He doesn't want to let me sleep at all." So you attempt to engage the baby, and when you smile and coo towards him, he's initially expressionless, like blank face, and then he starts to cry. The mom reaches across him and puts a pacifier in his mouth, pops it in without saying anything or making any eye contact with the baby. So I want to see your faces. I'm going to see if I change my view here so I can see people. I'm wondering what reactions people have to hearing about this interaction. This is not unusual. This is something that those of us who work in these settings see a lot. I think most people, whether they have any background in healthcare or not, have a reaction to this description that's sort of visceral. And I'm going to guess at your reactions because I can't see all of your faces. The first is that something feels a little bit icky or off, that the baby's facing away. The mom just sort of puts a pacifier in his mouth, sort of like kind of reflexively without trying to figure out why he's distressed. The statement, he doesn't want to let me sleep at all, that seems like a strange agency to attribute to a 4-month-old, that the 4-month-old is sort of trying to keep her from sleeping. And I would suggest that all of these factors tell us not that this is a bad mom, but rather that this is a mom who's in distress. This is sort of a warning signal. This is in mental health care, this is the equivalent of a patient who has a blood pressure of 200 over 120. This is like there's an emergency going on here. What the heck is going on? This needs attention. So when we're examining this baby, we want to see what the baby's temperament and mood and affect are like. What's the mom's affect like? Is she responsive to the baby? Does she read the baby's cues? This is described as a falling in love phase between mom and baby, or primary caregiver and baby. Do they seem like they're enjoying each other? Do they seem like they're falling in love right now? This is where you start to think about, all right, maybe I need to do some screening for depression or anxiety in the mom. Maybe I need to figure out, is there something else that's causing distress? Is there a safety issue? Is there a housing or nutrition or social support issue? How do I build rapport with this mom? Validate that having a 4-month-old is incredibly difficult. It's incredibly challenging and oftentimes very thankless for the mom. How do I celebrate any successes that I can see that might be happening? And then what are some specific issues we might be able to work on that would sort of build the mom's engagement? It might be around sleep or feeding, addressing her depression. So let's see what we learn next. So we learned that the mom completes a perinatal depression rating scale. We say, hey, we ask all new moms to do this. We'd love it. It'll really help us to take best care of your baby. She completes the screening tool and we talk her through the exam findings. We say, hey, your baby's in great health. You're doing an amazing job of taking care of this little boy. He really had a lot of fun playing with my stethoscope while I was examining him. I was cooing and he's cooing right back at me. We were really having a whole conversation. And when you share this with her, she starts to brighten up a little bit, but she still is kind of barely paying attention to the baby's enjoyment. So you score the screening tool, you say, yep, it really looks like she's depressed. So you begin to ask her, like, hey, do you know anything about postpartum depression? And she immediately starts to cry and ask whether she can speak to you confidentially. So here's what you do next, right? You say, okay, well, let's talk about confidentiality. Like, yes, this is confidential, but if I learn about anything that makes me worry about your safety or your baby's safety, I'm going to have to try to get help for you. You ask about what's causing the distress, because it's clearly that she looks distressed. Talk about the results of the depression screen. Ask about whether she's been depressed in the past. Talk about the good things that are happening with the baby and figure out what other kind of support might she need, including mental health support. So you explain to the mom, you're going to keep everything that she shares with you private, with the exception of any information that suggests that she or the baby might be in danger. She tells you that she recently moved out of her apartment because of concerns about domestic violence. Her boyfriend had been increasingly verbally abusive towards her. She's been staying with the baby with relatives for the last several weeks. For the last several days, she's been in a homeless shelter. She's feeling depressed and overwhelmed. She says she's not feeling suicidal. She's been able to feed and clothe the baby adequately throughout, but she worries that what's going to happen in the future. She acknowledges that she feels frustrated and irritated by the demands of the baby. And she's able to say, I know it's not his fault. So she agrees to meet with a social worker in the clinic, and she reports a history of abuse and neglect in her own childhood, which at this point is not surprising at all. This is how history repeats itself in families, and it's clear that there's a danger of repeating itself again in this family. So think about, like, if you were in that situation, what would you address next with the mom? How would you address the depression? What effect does untreated depression have on the child? We talked about how all of the child's emotional and social and cognitive skills emerge in a relationship with the mom. And if the mom is too overwhelmed with her own experiences of depression, of sadness, of grief, of loneliness, of isolation, how does that impact her ability to interact in a way that's going to build the child's emotional and social repertoire? How might that impact the mother's willingness to seek help for herself? And what I mean by that is oftentimes parents who wouldn't get help for themselves on their own, maybe they don't feel like they deserve it. If you help them to understand that getting help for themselves is the best thing they can do to help their child, that might tip the scale in favor of getting their own help. I find that to be very, very useful sometimes. So other, next things we might do, just so you imagine what happened in the clinic, screen for domestic violence. Is the mom safe now? Is the baby safe now? What are some sources of social support that can be turned on? Does the mom have a network that she can reach out to get some more support because she really needs it right now? Can she get access to public benefits like TANF and WIC and other sources of financial support for her and the baby to get access to financial, to dollars and to food stamps and other things to help them to be more stable? Could they get home visiting services? So have a nurse or a social worker come to the shelter or come to where they're staying to provide some additional support there. Involve social work. You can even do some exchange. These are called serve and return exchanges between an adult and a baby that help to build the baby's social skills. You can practice those right in front of the mom and help her to learn how to practice those herself and explain to her how she's building her child's brain every time she has one of those interactions. And then make her into a developmental expert. Explain to her what's going to happen developmentally next with her child, what happens at 5 months and 6 months, so that she can be looking out for positive developmental signs. They're going to help her to feel more capable as a parent. So I'm going to wrap up there. That's a very real kind of case that we see all the time. These are some great resources if you're interested in learning more about child trauma and child stress, also and about resilience and about the ways in which interventions that are being developed all the time are a really important part of helping to build resilience in kids just like that 4-month-old. I hope that that's illustrative as an example of how we sort of see the effects of trauma spill across generations and see these amazing opportunities for intervention beginning at the very beginning. So I'll stop there and happy to take any questions that folks have.
Thank you so much for that wonderful presentation, Dr. Biel. For our Q&A session, we ask that students enrolled in the seminar get to ask questions first, and then time permitting, we open it up to the general audience. As we are finishing at 1 today, we have roughly 15 minutes, and I'll go ahead and start calling on students who have their hands raised. Katiana, would you like to go first?
Sorry, there we go. Thank you so much, Johanna and Dr. Biel, for the presentation. I wanted to get your take, Dr. Biel, on the issue of shame and denial that presents often in intergenerational trauma. I don't have a healthcare experience with this, but I do have personal experience with this. People just refusing to believe that they have trauma in their own lives that has transitioned down to the later generations. Because I noticed that in your presentation, you discussed really great things, and that's great if the mother accepts, like, yes, I have depression, but I'm sure you've encountered, and many of your colleagues have too, people that say, oh no, I'm totally good, everything's great, and I'm perfect. So how do you deal with that?
Yeah, it's a great question, Katiana, and I think that anyone who works in healthcare, and particularly mental health care, knows that stigma coming from the outside, so from cultural factors in people's lives and social factors is a huge factor, and then stigma coming from inside of ourselves, the stigma that we feel about our own emotional distress and how acceptable or unacceptable that might be is a significant factor in people's willingness to accept help and to seek help. I think that there are, first of all, I would say that trends are positive. Like I think that, compared with 5 or 10 years ago, that people's willingness to talk about mental health and mental health challenges has never been higher. I don't know how old you are, but my sense is your generation is leading the way and people coming after you. Like I think that as I talk, and I get to see kids in my office every day, as well as at home, and kids' willingness to talk about their emotional lives and about emotional struggles is much less encumbered by stigma than in my generation or generations ahead, that are older than me. So I think things are moving in a very positive direction with regard to stigma, and it's still a huge factor. And so I think that there's ways around that in healthcare settings, like the one that I described. Parents will do things for their kids they might not otherwise do for themselves. I think language matters a lot. So someone who is unwilling to talk about depression may be willing to talk about stress. Someone who's unwilling to talk about anxiety will be willing to talk about feeling overwhelmed. And so figuring out different ways of framing things that we talk about is very, very helpful. I think the more that primary care doctors talk about mental health, the better it is for all patients, because they make it a normal part of healthcare. Now it's time for your checkup from the neck up. We've talked about your blood pressure and your heart rate and your breathing, and now we're going to talk about your mental health, and making that like an absolutely integral and normal part of every healthcare visit is really helpful. I had a dermatology visit recently, and my dermatologist asked me, screened me for depression, and I jumped off the table and wanted to give her a hug. I mean, I was so excited that had sort of penetrated like this sort of specialty area of medicine. So I think it's work for all of us to do. And I think we all have to also be aware of the way that we talk about this in our personal lives as well, and the way that we use colloquial language, and just be really, really vigilant that we're not unintentionally re-emphasizing or re-stigmatizing people who may be struggling emotionally.
Okay. Emily, would you like to go ahead and ask next?
Yes, thank you. And thank you so much for your time, Dr. Biel. I just had a question. Your whole presentation was really interesting, but I think it was really interesting what you touched on, like how in the US, a lot of our help is more reactionary to the problem rather than preventative. So I was curious if you've come across any other countries or even like specific areas in the US potentially that have found success in implementing sort of like a structure that is doing a good job at preventing those ACEs that we were talking about. If you've seen anyone have some success there.
Yeah, great question. And I mean, yes, there are hundreds and hundreds of really inspiring examples. And there's also really big, obvious examples, like like when the child tax credit was passed and was in place for a year, the United States in 2021, rates of child poverty in the United States fell by half. And then Congress did not reauthorize the child tax credit. And now rates of child poverty fell by half, and now have doubled, and actually are higher than they were in 2020, since the child tax credit was allowed to expire. So like the simplest, most obvious and scaled thing we can do is alleviate family poverty, because that has so many positive downstream effects on health and mental health. And relatedly, we can make paid parental leave be a normal part of every parent's life in the United States. We can make childcare affordable for every family. I mean, there are lots of families in DC that are spending 20 and 30 and 40% of their income on childcare, because childcare is so extraordinarily expensive. So there's sort of things that don't obviously have anything to do with mental health, but that just have to do with how hard it is to be a parent and to be a child in the United States, that would have a huge impact. And then with regard to mental health prevention, I mean, there's so many examples of really just speaking on early childhood, on what improves childhood development and childhood mental health, short-term and long-term, based on early childhood intervention. So home visiting is an amazing intervention that improves parent and child health, short-term and long-term. High quality preschools that are stimulating environments, that have well-paid, well-trained teachers, are extraordinarily helpful for children, building healthy brains and building their capacities to learn. And then there are a lot of really terrific those of you who are training clinical interventions for young children and their parents who've been affected by adversity, that are really effective interventions that have a very high effect size, that really do change long-term trajectory if we get the right interventions to kids who've been affected by trauma or adversity early on.
Thank you so much.
Sure thing.
Thank you. Rihanna, would you like to go next?
Yeah, thank you, Johanna. And thank you so much, Dr. Biel, for your presentation. So my question was kind of similar to Katiana's, and in reference to that specific example you gave, I actually used to work as a QMHP with domestic social services, and I used to work with a lot of kids in the foster care system. And something that I noticed is a lot of the time the parents would be aware of their own depression or anxiety, whatever problem they were dealing with, but they still faced what is it like inconsistencies, so they would be required to maybe like come and like meet with the kids or something, and they would have their own fears kind of get in the way. So when you face these type of situations, what is the proper way to really go about that? And then in the situation that, you know, it does extend beyond and the kids do eventually end up going into like foster care or something like that, what is the counseling that you would do in that case to get them kind of over this very traumatizing situation?
Yeah, thanks for the question. So, just so I understand the first part, you're saying what interventions are helpful for parents of kids where there's concern about abuse or maltreatment,
Yeah,
being
and I
able
think
to stay together as a family?
yeah, basically. I think, as I said, like one thing that I really noticed is a lot of the time these parents, they would be very much aware of their depression or anxiety of their circumstances, but they were unable to remain consistent um in going forward towards like their specific treatment plan. And so where do you really go in a situation like that?
Yeah, that's a challenging issue. I mean, I think unfortunately, um, as many of you know, like the it's really difficult to access good mental health care, even if you want it. Um, there aren't enough providers. There aren't enough well-trained providers. There aren't enough well-trained providers who take insurance, and who have availability in their practices. And so, even for people who want to get help and who recognize that they have challenges, particularly if they have limited economic means, we have real barriers. So it's sort of on us who are involved in health systems to try to reduce those barriers, to expand our workforce. A lot of work that we're doing at Georgetown is around expanding the workforce to include non-clinicians as part of the mental health workforce, sort of training community members and people who have lived experience in common with communities that we're trying to serve, to be able to do more parent-to-parent outreach and support, to increase access to timely support for people who have trouble accessing mental health care. So I think we sort of have to do all of those things to make care more available. And then I think for people, for anyone who's ever been in mental health care themselves, you know that it's a journey. It's rarely the case that you sort of decide you want to get care, you make an appointment, you go next week, you go for 6 or 8 weeks, and then everything's all better, and well, that good thing that's behind me. It usually doesn't go like that. It's usually much more of an ongoing part of our lives and part of maintaining our health. And so I think that we need to give that feedback to people, that you shouldn't expect to get better right away. This is something that's going to be a process. It's going to be, let's figure out what are your goals in your life that you can achieve. And for many parents, keeping custody of their kids is a really profoundly important goal. And so that can be really, really motivating and engaging for families. And I think on the provider side, we need to stick with people when they fall in and out of treatment. We need to sort of keep working to keep them engaged, because you're absolutely right. There's a degree of inconsistency and sort of cycling that's sort of part of mental health care. We have to be prepared for it to be built in. And I think it's really important to do everything we can to keep families together, because kids really belong with their parents.
Hello? Hello?
Dr. Biel, if you're okay with answering a couple more questions, I just wanted to check in and make sure you were okay on time.
Yeah, I've got a couple of minutes. I'm happy to. I'll do the best I can.
Okay, wonderful. I saw that your Etsy had a question, but was having trouble raising her hand. Would you like to go?
Yes, thank you. Thank you, Dr. Biel. I actually just came from like a medical appointment, so like I kind of like it's really fresh on my mind. I was able to see like kind of how you said like the case study, like how the doctor like kind of like looks for the mother to see how they're doing mental health wise. So I was wondering if there was any kind of like integration with the healthcare system with kind of giving parents like more guidance on like parenting, because we kind of do like the more reactive part, but parents, like I was shocked how how it feels like they just hand you a baby and then you're supposed to like learn what to do with it on your own. So if there was some kind of like something that you see could happen in the healthcare system.
Yeah, isn't it extraordinary that like the absolute most difficult job and absolute most important job on earth has no user manual, no training. You know, you have the baby and 24 hours later they're sending you home and you're supposed to just figure it out. And you know, most cultures on earth have cultural practices that help parents to support that transition, that new process. And the way that we live in this sort of like postmodern world, like a lot of those structures are gone. And so people really are on their own. So yes, there's lots of examples of things that people are trying to do in healthcare. An example to look up if you're looking for a specific kind of model is called Healthy Steps. It's a national model of putting early childhood and family support into pediatric practices, so that there are early childhood mental health specialists and parent support specialists that are part of the pediatrics team and meet with parents during the first 3 years of life to address all the topics that we're kind of covering today. So that's an excellent sort of example to look at. I can do one more question. Unfortunately, I have to run a meeting now, but I'll do one more question.
Right, wonderful. Thank you so much. Anya, would you like to go?
It's totally fine if you need to keep this brief, but I was just curious. So it seems like scaling up the interventions that you've talked about, like family poverty intervention, parental leave, childcare affordability, we need to have like really clear data that make a very promising case that addressing these adverse childhood events would really alleviate a strong financial burden from the healthcare system. So just curious, like, what is the status of this recent research with reference to ACEs and other early childhood trauma relating to like healthcare burden? And like, how much is this in the health policy conversation, in particular with reference to like poverty in early childhood?
There's a lot of conversation about it, and it's really complicated because from a policy standpoint, it's sort of there's a thing called like a wrong pocket problem. I think that's the right name for it, which is you have to spend money from this pot of dollars to save money in that pot of dollars, and they're not responsible or accountable to one another. So there are early childhood interventions that are extraordinarily helpful and they cost some money. So if that money is spent by the healthcare system and we're saving money to the educational system or the criminal justice system later, we have to make sure that those count, that those savings count. Because like a lot of what's happened is that we try to make the argument that it saves money to the healthcare system. And that's long research. You know, that takes 60 years to establish, right? If we're going to be preventing obesity and diabetes and cancer 60 years down the road. So we need to be able to do research that shows that that there is payoff. It just may be to other systems or other part of our larger society. There's great examples of research around this area. I can, I'm happy to share sort of bodies of work on what's the return on investment. James Heckman is a Nobel Prize-winning economist from the University of Chicago who's done a lot of research showing the return on investment of early childhood programming is about $15 to every dollar invested. And there's that research has been replicated again and again and again. One really interesting body of work that's happening now is around doing cash transfers to families that in the first few years of their family's life. So there's the big NIH-funded study called Baby's First Steps, where they're looking at the influence of about $1,000 a month going to families during the first 2 years of a baby's life, and the impact that has over subsequent years. Again, obviously only families who are experiencing a lot of economic precarity, but the influence that has on that child's mental health, developmental health, physical health, and educational achievement over subsequent years. So that's one example. There are a lot of studies that are going on in this area right now. Locally in DC, you can check out our work is the Early Childhood Innovation Network, ECIN.org. And so we're doing this kind of work as well, looking at how early investments impact longer term outcomes.
So thank you very much, Matt. Dr. Biel. Dr. Biel has put his email in the chat if anybody wants to write it down. If you have comments you want to send along, I thank you for that as well. And thanks to all of you for your attention and participation in what I really think was a great seminar this afternoon. Any last words, Johanna?
Oh yeah, just on behalf of all of us, thank you so much. This talk, I think, brought together a lot of ideas that we touch on within the HAPI program. So we're just very thankful for your insight and your time.
Really appreciate the invitation. Good luck, everybody.
Thank you.